All right, we're good to go.
All right. Well, hello, everybody. Whoops, my Zoom is acting out. Sorry, not Zoom, Microsoft Teams. As you can see, I mainly use Zoom and not this. So hello, everybody. Welcome. It's very exciting to kick off the recruitment season this year with our open house. So we are very excited to have you all here and welcome. We think it's really awesome that you all have chosen the field of neurology. It is a fascinating specialty, super dynamic, lots of changes. And we are very excited to showcase our awesome program to you. So I'm gonna start by just showing you your agenda for today. So we're gonna start introducing ourselves. So you know who you're talking to. We'll do a brief informational presentation, just a few PowerPoint slides that hopefully will answer some of the questions that we've already gotten, and just to give you a little bit of an idea about our program. And then we're gonna talk a little bit about what is it like being in Iowa City. And then we're gonna end by a Q&A session. So please feel free to submit your questions. We will be monitoring those as they come in. This was a recent picture from our residents back in the spring, I believe, where they went to Coconut Caves, which is a pretty neat area. It's about like an hour and a half away from Iowa City. So as you can see, our brave residents are descending into the caves here. All right. Now, moving forward to introducing our wonderful panelists. So I'm going to start by myself. So my name is Lama Abdelwahed. I am the program director as of 1 month ago, but I'm not new to the program. I've actually done my residency here, followed by a fellowship in neuroimmunology and neuroinfectious diseases. I'm originally from Syria. I did my med school there, and Iowa City has been my home since basically 2017. I have been the associate program director leading up to just recently where Dr. Swenson, who's on this call, and myself has switched our roles. It has been a blast being part of this program, and I'm very excited to see where we can take it further. Like I said, I've grown up in this program, so I'm definitely very invested in the future, and I'm excited to showcase it to you. Next, I'll give it to Trey. If you want to go ahead and introduce yourself.
Sure. Hi, everyone. I'm Trey. I'm one of the chief residents. I'm the academic chief for this year. I'm from Iowa originally, did all my undergrad, medical school, now residency here, so kind of stuck here for life, it seems. So if you have any questions about Iowa or anything like that, I might be the longest tenured person here at this point. I'm not sure. Maybe Frida. But my wife's a family medicine doctor. I have one kid, one more on the way, and excited to be with all of you here tonight.
All right, Zach. Did Zach sign in yet?
I'm here.
All right.
Hey, everyone. I'm originally from Chicago, born and raised, at undergrad at Loyola, med school at Rosalind Franklin, and then came here for residency. I intend on doing a movement disorders fellowship. I'm married with 3 children, none on the way. 3 is enough at the moment. I've really been enjoying Iowa, change of pace from Chicagoland. So happy to talk about any transitions like that.
Awesome. And Frida.
Hey everyone, I'm Frida. I grew up in Texas, border town with Mexico. I went to college in St. Mary's in San Antonio, Texas, but I've been in Iowa since 2014. I did med school, graduate school here, as well as residency, and I'll be staying here for epilepsy fellowship. So I think I did beat Trey by a little bit.
All right, and then let's see. I'm not sure if Tracy has logged on yet or not. So Andrea, I'll give it to you.
Hi, I'm Andrea Swenson. I am one of the faculty members here. I went to medical school at the University of North Dakota and did my residency here at Iowa a while ago, but it was in this century. That was followed by a neuromuscular medicine fellowship at the University of Illinois at Chicago. And then I came back as faculty. And as of July 1st, I am a newly minted Associate Program Director. As Dr. Abdullah had mentioned, I was Program Director for 12 years, and we made the swap just a bit ago. And this has allowed me to focus more on the neuromuscular division. I direct the ALS multidisciplinary clinic as well as our myotonic dystrophy clinic. These are very active in clinical care as well as clinical research. So it's allowing me to focus more on that. But I really love this program. It's been really fun to be a part of it, and working with Dr. Abdullah Head the past year. We've been kind of tag teaming all of this, has been really fun, and I'm super excited to see all the changes she's going to tell you guys about tonight.
Awesome. And Tracy, I think you're on now.
Good evening. My name is Tracy Cho. I'm Vice Chair for Education for the department. I am not originally from Iowa. I moved here in 2018, and now I'm proud to be a Hawkeye. My clinical focus is neuroimmunology. I'm the division director and the fellowship director for neuroimmunology. And Dr. Abdullah Head was my first fellow, and now she's already surpassed me in every way.
Stop it, making me blush. All right, and last but not least is Caroline, who makes everything happen.
Hi everyone, welcome. I'm Caroline Martin. I'm the program coordinator. I am originally from Iowa, and I've been with the department a little over 10 years, and I've been with the residency program, I think a little over 6 years now. So happy to answer any questions. And I'll also add, if you at any point have questions, you can go ahead and put them in the Q&A, and we'll be responding to those as we go along.
All right, thank you for our panelists. And I should add part of our team as well, a bigger part of our team is Dr. Kardec, who is one of our associate program directors and has had a big hand in creating a lot of our newer curricula. Most recently, we started a very brand new EEG course that we're all very excited about. He's not with us tonight, but you'll certainly meet him along the way. All right. So to go back to a little bit of an informational presentation. So the University of Iowa has a long history. Our program is one of the oldest in the country. I think it's the third oldest in the country. Here you can see, like, you can feel the history when you walk into the hospital, both exterior and interior, and you get a sense of how far along we've come in medicine. This is a photo from the 1940s. You can notice like the old car here. At the main, that was the main hospital entrance, and this elaborate Gothic tower that stood above everything else. I think it was established in the late 20s. And now things have changed a little bit. So it has grown a lot. As you can see, the tower still stands proud and strong, but the campus has expanded hugely. So now we are at like an 860 bed facility with a newer 190 bed children's hospital that is adjacent to the main hospital. And not just that, across the street, so this is where we started, the old tower, this is the main campus. You can see across the street, there's the VA hospital that has 83 inpatient beds. Our residents get to rotate in, and between the two, this is basically makes a very large academic center with extensive catchment area that serves all of Iowa, but not just Iowa, also like some of the states surrounding it. So we get patients from Western Illinois, from Missouri, and some from Nebraska as well. Two people that we want to give shout out to that are very important to our department. We have Dr. George Richardson, who is our department chair and oversees all that we do from clinical research, education standpoint, and it has been a fantastic leader and mentor to all of us. By us, I mean both faculty and mentor and trainees. And then here we have Dr. Dima Fatal, who is our VA site director and chief of neurology. And she directs the residents' clinical experiences at the VA and is a well-being and whole health guru who has been an excellent resource for our patients and for our trainees on how to manage your personal well-being. Some of the other UIHC locations, I mentioned the Children's Hospital. Some of you who are big on college football may have heard about the nicest tradition in college sports, which is the wave. So our Children's Hospital is right across from Kinnick Stadium, where all of the college football games happen. So that has been a big tradition that is pretty famous now, where people, I think at the end of the first quarter, they turn and they wave at the children in the hospital. You will rotate there during your peds neuro rotation. There is another separate, mainly outpatient building called Iowa River Landing that is just like a, 5-minute drive away from the hospital. You mainly go there during your internal medicine year for some subspecialty clinic. And then the other two campuses that were just recently either acquired or built, we have no presence there, but just so you know that these exist. So we have North Liberty, that's mainly orthopedic hospital in the downtown campus. All right. So the overall goal of our program is to provide the best neurological training for our residents that fulfills all of your career goals, whether it's like practicing community, working at the academic center, or becoming clinician scientists. So doing so, we want to make sure you have it in a welcoming and supportive environment. And we do this by providing comprehensive clinical experiences, high-quality education programs, and empowering both residents and faculty to contribute and collaborate, excuse me, in advancing our program forward. And as the field of neurology has changed, so have we, and these changes we've experienced so far have come really through all of the collaboration between our faculty and our trainees. We really highly value the resident feedback and rely on them to help us move forward. So we do have established monthly house staff meetings. So myself, Associate PDs, Caroline, we meet with all of the residents, and we kind of have every month we have a new agenda, and we discuss what's going well, what's not going so well, what needs to be changed, etc. And that's where all the enhancement and changes have come up during our program. Excuse me. All right, a lot of questions we get are about the PGY1 schedule. So our clinical experiences begin with the PGY1 or intern year, which is a combination of rotations through internal medicine, psychiatry, and then our ICU, which is surgical and neurological combined. And during that first year, we feel it's important to also rotate through neurology, especially to start building neurology foundational knowledge, gain exposure to the field, and hang out and get to know our neurology team. So our interns will spend 4 weeks with us on the general neurology inpatient service and 4 weeks on the outpatient clinic. But potentially the best part, and I've been part of this as a resident and as a mentor, and I would say this is definitely the best part of the year, which is the last rotation that we have, which is our neurology immersion block, or as we call it affectionately, the boot camp. So during this, you have no call, no clinical duties, no rotations. You just go through an intro to neurology, focusing on emergencies, getting ready to being on call, workshops like LP, simulations, getting to know basic EEG, EMG rules, and all sorts of things like team building. In the past, we've had retreats as well, so all sorts of fun things. This was our latest brand new interns who started this past July. So this is really a fun year to have before you dive into neurology. Excuse me, I have a cold, that's why I sound like that, but I feel fine, I swear. Anyway, our clinical curriculum, as I mentioned, our program champions for change and values contribution from the residents. And a big change that got significant input from the residents was our clinical PGY2 to PGY4 years is now switched and based on X+Y model. This has been in place since 2019, and every year has really gotten better and better. And our residents really like it because each resident has their own continuity of care clinic, or what we call COC clinic, which allows them to have their own patients and develop reports with these patients who call them their primary neurologists. So COC in the past used to happen every week, no matter what type of rotation these residents were on, whether inpatient or outpatient. So it was pretty disruptive to both the inpatient duties as well as the clinic duties, and that's what brought this change. So for those of you who don't know, X is the number of weeks on a specific rotation, NY is the 1 week of like COC clinic that also includes subspecialty clinics, plus admin time for the residents to catch up on notes, phone calls, amongst other things. And we find this to be really much less disruptive and actually improve the continuity of COC clinic. It does provide a better predictable schedule, especially when you're trying to plan your weekends off. And most recently, we just added this past July, actually, 2-hour small group teaching session on Wednesday morning for the Y week residents, which includes 2 case presentation or a journal club and a 1 case presentation that is led by the residents and moderated by a faculty member. And so far, as far as I know, it has been a huge hit. So, and I've moderated several, and it has been super enjoyable. And with this schedule, we found other benefits specific to the PGY2 year. So during this year, our residents start to get familiar with treating neuro emergencies, taking care of sick inpatients, but in addition, wanted to make sure they get early and much needed exposure to the different subspecialties that we have available. So they can try to accomplish that in the outpatient setting. So we have to put together themed weeks where the PGY2 residents can focus on a particular subspecialty clinic during that set week. And then the week following that, they'll switch on to a different subspecialty. And with this, our residents can see what fellowship opportunities are out there. And we're able to build in as well some PGY2 elective time for them to explore these interests. This is a sample of the Y or COC week. We do have COC clinics at both UIHC and the VA. And residents do appreciate taking care of those 2 different patient populations. So as you can see, we have kind of on average 4 continuity of care clinics, 2 at the VA, 2 at the university, and the rest is distributed between subspecialty clinics that are the faculty clinic. That we have that small group learning session on Wednesday morning and then admin time. Now, our PGY2 and PGY3 residents spend about 5 months on inpatient services, which include our stroke team, general neurology team, inpatient consultation team. There's the EMU as well, epilepsy monitoring unit, etc. And then our PGY4 residents have about 4 months of inpatient. And also we have a good amount of subspecialty clinic during the PGY2 year, as we mentioned, and throughout residency as a whole. For call, we have night float system, which is 1 week and a night, so 6 nights in a row. And the PGY2 is a junior on night float, and they are a buddy system, so they have with them in-house either a PGY3 or a PGY4. And our residents really do like the 2-person call team, which provides a lot of support for the junior resident, and the senior resident gets more autonomy. We have multiple faculty on call for different services, and they are readily accessible for any questions and for support. So that's how our night system is. So we no longer do 24-hour call. And then for electives, we are excited to offer many different types of elective for our residents. Here we have listed some of the more common choices. And our residents, for example, really enjoyed advanced neuroanatomy and collaborating with one of our neuroanatomists to learn more about it, especially before the boards as a review. We also have really enjoyed working with the residents and seeing them how they get creative on creating their own electives. So we've had people who wanted to go into neurocritical care, customize their own with our collaboration with our ICUs and our ED services. We've had people customize their own neuro-oncology service. So really, we can try to make happen whatever you really want to do. There's also research electives offered that you can take time to work on a project with the faculty. We have community electives. We have really strong relationship with neurologists throughout Iowa, so that allows us to send the residents to work with them and see what it's like outside of an academic setting. And then we have OA rotations available as well. And here at Iowa, we provide our residents with well-rounded clinical experience, exceptional didactics, and multitude of research opportunities. So we are the only academic medical center in the state of Iowa. So you have a really diverse patient population with great cases, not just the bread and butter of neurology, but also plenty of rare diseases. Our faculty represent multiple neurology subspecialties, so residents get exposure to all aspects of neurology. And we utilize AI-powered node generation software, so we have much more efficient practice, and that allows our trainees and faculty to focus less on the node documentation and more on what really matters, such as spending more time with our patients and less on the computer. And this year, we have actually, for the didactics, eliminated daily Zoom conferences in exchange for more condensed 2-hour didactic sessions, once or twice per month, that is separated by the class level. So we have specific didactics for juniors and specific didactic for seniors. Lunch is provided during those, and the time is protected from clinical duties. And these sessions focus on high-yield clinical neurology topics and board review, and they've been very informative and have been rated highly so far. We also host weekly grand rounds with internal and external speakers, and there are additional optional conferences throughout the week, such as Neurology, tumor board, muscle pathology, brain cutting, and every other month we have a medical education specific session. And as you can see, a lot is happening to supplement the resident clinical encounter. And for the entirety of our didactic curriculum, we utilize resident feedback as well as in-service exam scores to help tailor the sessions to our program's needs. And lastly, for research opportunities, there are many mentors to guide resident scholarly projects. We are a site for StrokeNet, and this allows us to be a site for multiple clinical trials. For the stroke trial in particular, residents are an integral part of our acute stroke trials, because you guys will be basically the front people to meet those patients and potentially triage them and consent them. Excuse me. And other than that, you can also jump in on several other projects like QI projects, educational, basic research, especially through our robust Iowa Neuroscience Institute and Iowa Center for Neurodegeneration. This was most recently our now PGY4 class at the most recent AAN session. And this was from one of the poster sessions that I've done years ago that we have started doing again last year, I believe, for the residents and students. All right. So other than your typical research, clinical experience, educational opportunities, didactics, we have created designed tracks within our program to enhance residents' educational experience. So first, we have the Clinical Neuroeducator Training Program, or CNETP for short, which provides training in the foundations of medical education as well as educational opportunities with learners. And residents in this track acquire skills to become effective educators, develop and implement scholarly projects with goals of becoming future education leaders. I myself was actually a graduate from this track. It was one of the main things that attracted me when I was in your shoes looking at programs, and one of my favorite experiences as a resident. Dr. Karnak is another graduate as well from this program. And other cool things about our residents is that they are excellent teachers. So they have won and they've been nominated to several teaching awards on an institutional level. Also nominated by our medical students. We also have a formal tutoring program that the residents tutor students 101. Usually students who are going through the neurology clerkship and looking for additional support. And there's a stipend that comes with that, which is pretty nice. This photo here was from, I think, a couple weeks ago, where we did an escape room style CNETP session where you had to practice different styles of teaching to kind of get through the clues and figure out the mystery case. It was a lot of fun. Now, the counterpart to the CNETP is the CNSTP, which is the Clinical Neuroscientist Training Program, which is designed for trainees interested in pursuing a career in academic neurology who have already demonstrated proficiency in biomedical or clinical research. This unique program is supported by the NIH grant and provides close mentorship and flexible scheduling to balance research and educational goals. Additionally, 2 of our current faculty, so Dr. Aldridge and Dr. John, both graduated from our CNSTP and have their own labs and have secured multiple competitive independent funding. Well-being, culture, and belonging are extremely important to us, and we are committed to creating a supportive environment for everybody on our team. So our well-being team has compiled resources from mental and physical health, including facilitating resident access to primary care providers, Our GME has hired so far 2 psychologists who work solely with residents and fellows and are excellent resources for well-being. And we are continuing to develop strategies to reduce burnout, finding ways to decompress, and discuss challenging and difficult cases with each other, as well as helping each other achieve work-life balance. We provide enhancing mentorship both at the faculty and the peer level. And we have frequent check-in from both our leadership and our chief residents. So I personally will meet with the resident individually to see how things are going. We have several faculty, education faculty mainly, that meet with the residents, and our chiefs so far have been doing a fantastic job making sure the transition of our interns have been seamless and smooth. And each resident, the mentorship gets brought up a lot. Each resident is assigned a neurology faculty mentor before even starting PGY 1 year. And our PGY 1 are assigned not only to neurology faculty, but to one of the internal medicine APDs during their intern year. So that way we make sure we have a safety net from every single angle. And lastly, we want to connect with our community and do this by bringing awareness of neurological disorders and providing shadowing opportunities for undergrad students to enhance early interest in neurology and neuroscience. And one of the great things about our program is that our faculty and residents staff the neurology clinic within the University of Iowa Mobile Clinic, which is largely a student-run clinic for uninsured population throughout Iowa. This photo right here is from the most recent graduation last month. And this one was from last fall, where we had a pumpkin. We wanted a pumpkin carving, but then decided for pumpkin painting because less messy event that was organized by Frida, actually. All right. Now, lastly, is just a little bit about Iowa City. So most recently, CNN actually named us as number 8 on the list of cities to visit in the US, which is pretty awesome. They call it the American city where almost everyone seems to be writing a book. This is the old Capitol, or the main campus of the University of Iowa. This is one of the famous bookshops here called the Haunted Bookshop. If you want to go find books, maybe meet a ghost, and cats. Apparently cats are big in that bookshop, so it's pretty cool. This is one of the areas in the north side in downtown Iowa City. So during the summer, you'll see a lot of places like that where the sidewalks and even the streets are taken over by restaurants. And then usually it's filled to the brim by the evening, where we have live music, different festivals every weekend. So there's usually a lot going on. It's a college town, so it's really brimming with life at all times. This was from the summer block party, which happens every summer during orientation time, actually, for the new interns. So you can bet that you'll find multiple residents hanging out in this photo. This was actually the silent disco, so everybody had like headphones on and they were jamming to their own tunes. Lastly, this is from an apple picking session last fall with some of our residents. And I'm gonna turn it back to our chief residents so they can tell you a little bit more about what is it like to live in Iowa City as a resident. So I'll turn it back to you, chiefs. Maybe Trey, if you want to go ahead and get started.
Sure, I can get started. So like I said, I've been in Iowa City, I think 11 or 12 years at this point, and I think it's served me well in kind of every role during my life as I've progressed a little bit. So if you're young and single and you want to live downtown above a coffee shop and walk and bike to the hospital, you can do that. And then during medical school, I kind of moved to a more mature neighborhood where the professional students were, and you can kind of get away from, the busy stuff like that, but still be close to work. And now with a family, kind of moved out to one of the suburbs that's a 15-minute drive away, and have lots of nice parks and activities for kids and everything like that. So I think kind of, it's small, but like Dr. Abdel said, it's very active with the college. You can find, if you're a sports fan, all the collegiate activities. If you're into literature, there's a lot to do with that around here. Very large Hauncher Auditorium where we host some Broadway type shows and concerts. And so you can kind of find what you want no matter what. There's good hiking and biking. We talked about some caves nearby. There's a couple state parks with lakes that I like to go paddle boarding at. So a little bit of everything. kind of packed into one small town. So if there's any specific activities you're interested in, I think pretty much everyone's been able to find what they've been looking for while they've been here.
Kind of to add to that, I've also been here for 12 years. I'm also married and I have a kid and another one on the way. There's a lot of state parks. We're a big outdoors family. We've done lots of hiking and camping there. If you're an avid cyclist, I wasn't when I moved here, but then I started biking more. There's this world famous bicycle ride across the state of Iowa. It happens in July every year. Has been happening for many, many years, and we've had people like Lance Armstrong join just for fun. So that's another thing that happens in July, and the route changes every year. I suspect this next year is going to come through Iowa City again, so I'm excited about that because I may join for a day. But yeah, lots of outdoor things. There's cycling. There's an apple orchard. Um, there's also like gyms with the university affiliated with the university that are very state of the art. Lots of, if you're into swimming, there's a lot of like Olympic sized pools. Like there's, I think, a little bit for everyone.
A little sprinkle of additional details to that, just as a dad of multiple kids. It's a very nice, safe area. With all the schools are nice. Plenty of activities that are free for families, which you wouldn't typically get in a big city. Weekly festivals and free things, which are always nice when you have children on a resident salary.
Yeah, I think another thing that maybe we glossed over was that it's very affordable. So your resident stipend goes a long way. And so, like last year, my wife and I went to the Dominican and Costa Rica on two separate trips and pay for daycare and bought a house and all these things. So your stipend can go pretty far here. There's not a lot of traffic, and so don't underestimate that when you're thinking about your quality of life and how much time it takes you to get to work and how much time you waste sitting in a car, and the type of housing that you can find within a reasonable distance from the hospital. I think everyone's been really pleased with their kind of quality of life outside the hospital while in Iowa City. I'd say maybe half of people in our class have like bought properties and maybe the other half rent. So there's a good mix, and it's certainly achievable to buy a house, buy a condo, whatever, when you come here if you're interested in that.
All right, thank you guys. I think we can go ahead and get started by some of the questions that were submitted beforehand. So if you want to go ahead, Caroline, and lead the show.
Yeah. Okay, so the first one we have is for Dr. Swenson. What are the qualities that we look for in a candidate, and how do you take into consideration letters of recommendation, USMLE scores, graduation dates, etc.?
Yeah, thanks. This is a great question, and we're coming upon application review here, I guess just under a couple months. But this is always a really exciting time for us. I really like reviewing applications. It's so fun to read about what you've done. Every year, I'm just so amazed by our applicants and the cool things they've done in school and outside of school. And it's just really, really fun to read through those. We do have a team of faculty who are our reviewers, and we take this very seriously. We block off time from our clinical schedule to go through applications because we really want to make sure we're being thorough. Our application process is very holistic. We do look at all aspects of an application, but there's not one single factor that we base everything on. We really take the whole application into consideration. I know there's a lot that's in the application, letters of recommendation. A lot of people ask about what those should look like. I think we're usually looking for at least 3 or 4 letters submitted. We do want to see that a neurologist has at least written 1 letter, because we want to make sure that people have had exposure to neurologists and have really gotten a feel of what the specialty is like and know that's what they want to go into. The scores, whether it's USMLE or the COMLEX scores, we do look at those, but again, it's not something that is going to make or break whether we invite people for an interview or not. It is part of our review, and we're looking at the whole application. I know some questions come in about whether people need to have both the COMLEX and the USMLE. That's not necessary for our program. We do look at both if they're submitted, or one if someone just submits one. A lot of questions come up about signals. This is something that in the neurology world we've had experience for just a few years. Now it's 8 signals for each applicant. An applicant can choose whether they want to use signals or not. Based off the data that we've received from prior years, it looks like the majority of applicants are using signals. Again, it is another point in someone's application that we look at. Signaling our program doesn't necessarily guarantee an interview, and not signaling our program would not exclude someone from our review process. So we do see them and look at them, but again, it's not going to be the sole factor in determining whether we invite people for an interview. Some other questions come up about research. Again, when someone has done research, we like to see it, we like to read about it. It's not an absolute requirement for getting an interview with us, but definitely if that's something you've done, we want to make sure you put it in that application so we can see it. And other questions come up about international medical graduates, and along with that, when people graduated from medical school. We do really value diversity in our program and really appreciate perspectives that international medical graduates bring to our program. And again, we're looking at the whole application and seeing what people have done. As far as when they graduated from medical school, it's helpful to see some continuation of clinical involvement between that graduation and now. So that's certainly things that we look for. Having some U.S. healthcare experience, I think, is helpful. We all recognize that sometimes there's limitations into getting those experiences, and we do take that into account. But it can be helpful to indicate a sense of what the U.S. healthcare system is like. As far as what we're looking at for future residents in our program, we definitely want to see a strong interest in neurology, and that can come through in applications with a lot of neurology rotations, research in neurology, or getting really good letters of recommendation for neurologists. We can see that this is a field that you're excited about, and you really want to practice neurology for your future career. So we definitely are looking out for that. Good communicators, as you've probably seen in your training so far, and what you will definitely experience in residency, is that there are so many different people within the healthcare system, and we really need to be working well and communicating well with all of those people to provide the best patient care that we can. And with that, being a good team player, and that's something I really appreciate about our residents, is that they get along with one another, and they really seem to enjoy working alongside each other. And that really helps in their learning as well as what they can do for patients. So yes, that was a lot. Hopefully that answered that question. And again, feel free to enter anything into the chat if you have more questions about that.
Okay, thank you. All right, next question for Dr. Cho. What are the mentorship opportunities like, and how do we tailor training toward each resident's specific interest?
So as Dr. Abdullah had mentioned in her introductory presentation, each resident is assigned a formal mentor, and that is kind of the floor of what we do in terms of ensuring there's a formal connection. That person is assigned an intern year and is responsible for meeting with residents at least twice a year and formally reviewing their evaluations, their career goals, later on their in-service test scores, preparing for fellowships, preparing for boards, and generally serves as a mentor for all their needs. That is, as I said, the minimal amount that is guaranteed through that formal process. What happens in practice is it's really organic, and our faculty have an open door policy and frequently interact with our residents. The vibe is very collegial and casual. So there's very few barriers for residents to approach faculty. I have the good fortune of having an office up by the resident area. And even when I like to have the lights off because I don't like fluorescent lights, the residents know that. They're always welcome. And every week or so, I get to review cases they have questions about or talk about career planning. And that goes for all faculty. So your assigned mentor may not end up being in the specialty that you apply in. And it is very easy to connect with those faculty who are in your specialty area. And so I would say most residents have a mentorship team, and it's not one faculty. There's also more senior residents or your chief residents who often serve as one of the most important mentors as well. It is also very easy to connect with faculty outside of our department. It's a very collaborative environment in general. So where there's expertise beyond the department, your neurology faculty can often connect you, and that's also a very easy path. In terms of tailoring to each resident's individual interest, I think that's one of the most appealing aspects of our curriculum is the flexibility with the electives and the wide range of experiences that are available from research and basic science to more data driven and clinical research with data sets to education scholarship and career trajectories towards medical education. There are also opportunities both in the department and beyond for other aspects in public health and quality and safety. And so if a resident wants to spend more of their time doing one of those extra curricular career development, the program definitely supports that. It's also a program that will be open to resident initiated projects or changes or experiences. And so I've been very impressed and have tried to contribute to that culture and that openness to not a one size fits all, but a very individualized training experience. Of course, we guarantee that every resident learns neurology very well and is equipped to take care of any neurology patient when they graduate. But people get that in different ways and at different rates. So we're very happy to have the resources and expertise to offer other tailored experiences as well.
All right, thank you. All right, next question for our chiefs. What is a typical day and night shift like in the life of a resident at Iowa?
I can start with I'll start with the night shift just because that tends to be a little more uniform. Um, when you're in night shift, it's a buddy system. Like we talked earlier, you have a junior, so a PGY2, and you have a senior, which is typically either a PGY3 or a PGY4. On nights, you cover all of our services, so that includes our general inpatient neurology service. You field new consults in the hospital. You also field, we also cover like the inpatient stroke team, code strokes, and just generally any new like ED consults and such. The junior also fields urgent consults that happen across the street at the VA. So there's a code stroke at the VA, the junior goes to the VA and goes ahead and and drives for the code stroke. And these night shifts usually happen, or these night shifts happen during night float. And then we also have a couple of call shifts that happen on Fridays, depending on whether you're on a continuity of care clinic week or if you're on the EMU inpatient service. That's usually when we have those night shift call days. Zach is on consults right now, so he can talk about what a typical consult day looks like. And Trey, I forgot what you're doing. Oh, you're at the VA, so you could probably talk about what you're doing when you're at the VA.
So yeah, being on a consult service, sign out from the night team is at like 6:45 or so. So your day kind of starts just before 7. You sign out to the night team at 5. And you field new consults in the hospital, whether it's the emergency room or the floor or the ICUs, and it's pretty, you know, similar day to day. You round on pre-existing patients that you have to follow up on, and you take the consults as they come in. Um, on the consult service specifically, we have what's called EEG rounds in the afternoon, where we go down to the epilepsy reading room with a epileptologist and like review studies on our patients and help us guide what our anti-epileptic management might be or get them off continuous EEG monitoring, things like that. And then the other inpatient services are going to be similar. General neurology inpatient, where you're the primary team. So you may have some discharges that day, but most of the time the consult service will be admitting to you, and then you just kind of follow up with them the next day. And then the biggest one would be the stroke service, where you're primary. And again, the sign out is the same time those days. Uh, the VA is actually pretty similar. So maybe Trey, do you want to talk about the VA briefly, and then maybe what call shifts might look like?
Sure. And wait, did we hit on like a clinic day as well, or
Not yet.
not yet? So, the VA is a little bit different. It's a little slower. So as the VA resident, you're in charge of like the inpatient consult service. So you're there fielding new consults from 7 to 5. And because it's just not quite as busy, there's not as much volume there, you're responsible for like strokes or general neurology consults, kind of whatever comes in there. Um, because it is a little slower over there, you also have the potential to see some like urgent add-on clinic patients that can be mixed in a couple times throughout the week. Like 2 to 3 patients a week can be added on to the clinic for you to see. And then you're also kind of the point of contact for like the clinic triage nurses. If someone's calling in with acute concerns, they'll forward it to you, and you kind of try to read through their records, maybe call the patient, figure out how urgent it is, and kind of help triage. Is this someone that needs to come to the ED and see me now? Can we add this person on to clinic? Can I, deal with these problems over the phone? That sort of thing. Um, on call, it functions a lot like night float in the sense that there's always going to be a junior and a senior on call, and your call shifts will be from 7 a.m. to 5 p.m. And usually when you're on call on the weekends, a lot of times you're also on another primary service. So you may be on the consult service for the day and also on call, or you might be on general neurology and also on call. There's a handful of times where sometimes the junior resident on Sunday sometimes is just on call and on no other service. And so sometimes you'll be responsible for rounding on a few people with your primary service and then taking anything new that comes in during the day. So that can require a little bit of juggling. If you're in the middle of rounds and a stroke comes in, you kind of have to figure out how you want to triage those things and which patient's sicker and needs your attention up front. Um, and then clinic, almost all the clinics are just 8 to 5. We saw like the breakdown of a typical week. You may have 1 or 2 half days off for administrative duties, and typically a half day for educational things, and then usually 4 half days a week of your own clinic, 2 at the university, 2 at the VA, and then maybe the remaining 2 or 3 half days in a subspecialty staff clinic. And you'll see 4 patients in a half day at the university, and the VA can be anywhere between 3 and 5 in a half day, depending on how many are new and how many are returns.
Okay, another question for the chiefs. How does resident autonomy progress through the years, and how does the presence of fellows in specific disciplines influence resident education and autonomy?
I can
Since
start with that. Oh, sorry, go ahead.
No, go for it, Frida.
We start being exposed to neurology in PGY 1 year. We have that outpatient neurology block where that's what it's labeled as, outpatient neurology, but you can kind of make it what you want it to be. So, for example, in my case, I was debating between like clinical neurophysiology, sleep, and epilepsy. And so I did a mix of rotations with clinic because I wanted to see the outpatient setting. So I did maybe like 2 weeks of a mix of sleep clinic at the IRL, the Iowa River Landing. I did some epilepsy clinics as well. And then I think I spent some time in the EEG lab. And then the other 2 weeks, because I'm in the research track, and we can talk more about that later, I also spend it kind of identifying a mentor in a project. That first exposure in PGY 1 year really helped solidify what I wanted to do and what I didn't want to do. And so that's how early you can start. And then through PGY 2, you and we'll also talk more about this. I think one of the questions is about EEG and EMG and the LPs. But the exposure they have to fellows specifically, so you get exposed a lot to the stroke fellows. PGY 2 is a little more inpatient heavy, as you guys saw in the breakdown earlier in the slides. You interact with the stroke fellows. For the EEG and the EMG, you also interact a lot with the clinical neurophysiology fellows. You occasionally interact also with the movement disorders, not as often as the others, because usually when you rotate through the movement disorders clinic, you work one-on-one with the movement disorder staff. And neuroimmunology, usually when we have a very complex zebra or a straightforward neuroimmunology patient, we involve the neuroimmunology fellow as like an add-on extra. I guess they're the smartest people. That's what I usually say. And so they kind of review the whole patient case, and they kind of walk you through their thinking and the workup. And so you get exposed to a lot of these fellows. Oh, and the NIR fellows and neuro interventional fellows. And code strokes, when you have a patient that's a candidate for like an endovascular therapy or mechanical thrombectomy and things like that, you interact a lot with them. You help wheel the patient to the OR sometimes, and kind of sometimes later on in your PGY 3, you are involved in like the consenting process, things like that. So there's a graduated increase in how involved you become with the fellows, and it continues to solidify what interest you have. So in my case, I was already interested in epilepsy when I started it, but I was still debating whether I wanted maybe sleep, maybe just clinical neurophysiology. And I think as I continue to tailor, what I use my elective time as, because that's another thing that you'll do is you have elective weeks. You can choose what you do with those elective weeks, and that's how you look into what specific fellowships you're interested in.
Yeah, and
All
then I
right.
think another part of that was like autonomy and whatnot, and obviously the farther you get into residency, the more you get to do, and by the time you're a PGY3, you're sometimes when you're on call or at night, you're the most senior neurology person in the hospital, and so you get to kind of triage how acute things are and initiate, preliminary game plans and everything, and really get to call the shots. And you have, like Dr. Abdel said, you have your stroke staff and your consult staff, your EEG staff, everyone on call if you need them. But you definitely get the chance to kind of be a little more independent and autonomous overnight.
Okay. Another question for our chiefs. How would you describe the culture of the program, and can you give some examples of how faculty support the residents?
I would say that the culture is very outgoing, and if you're a jokester like myself, you're allowed to be yourself and joke on rounds or in clinic, and make those funny quips with your elderly patients in movement or cognitive clinic, and make those connections with families. I think I have probably every attending's phone number by the time I reach like middle of PGY3 year. Um, and a number of the attendings are very open to you calling them, running cases by them, even if they're not like the staff on call. And the staff, they always want you to reach out to them if you're on call overnight or on weekends, or if you have a complicated clinic patient and they may be of that special subspecialty. So yeah, I think it's very collegial, and I think it's kind of built in also with the buddy system when you're on call, and when you also just have your juniors and seniors on inpatient services together. So I think it's very much a group effort, and everybody supports you in what your overall goals are with your career, whether you want to be a research scientist or go practice out in the community and build your own private practice or things like that. So
Yeah. I think another thing about the culture that's maybe unique here is we have kind of a unique workspace that's situated a little bit off of the actual inpatient units. It's just a couple minutes walk, but it's not right there. And so all of our work rooms are up in that little unit. And so, even if I'm on stroke and Zach's on consults, I can still go bug him about things and call him old and make fun of his gray beard. But so you get to see all your co-residents every day, and you get to, run cases by them or make plans for dinner or the weekend. If you're really in a pinch and you need help with something, people will offer to offload that lumbar puncture if you're really busy and they're sitting around and their service is slow and they say, yeah, let me help you out with that. So I think, you're not kind of tucked off in this little box in a little closet workroom throughout the day. We're all kind of hanging out together regardless of what service you're on.
Okay, still with the chiefs, what support does your program have for starting families, maternity leave, parental leave?
We're all grinning because I'm probably due this weekend, and right after me, Trey is also his family. They're also expanding their family. Um, so for maternity and paternity leave, which I think is kind of a unique thing, and I think paternity leave is semi-new, at least in the past 5 years, maybe. We get 6 weeks of parental leave. That also, I think, has expanded to residents of families that are adopting. So I think that's another unique thing. If there's like an unexpected medical complication, sometimes that paternity leave or parental leave can be expanded a little more. All keeping in consideration your training time. So anything longer than that can sometimes affect, your graduation date. But I think there's flexibility in kind of expanding that if necessary. But right now, I think the standard is 6 weeks of parental leave. I don't know if Trey, you want to add something else?
I guess like in terms of supporting families and whatnot beyond the leave itself, there is like there's a program through the university that can help with like childcare for sick kids. And so if you're in a pinch and your kid is sick and daycare won't take them, there's resources through the university to help with emergency and backup childcare. There's a few daycares associated with the university on the hospital campus, and many of them throughout town. If they're not directly associated with it, you also get a discount or a subsidy if you work for the university. Um, what else? And then I guess like we've talked about too, just the culture and everyone's kind of in it together, and that goes beyond the formal policies, but it's really helpful to have residents who say, oh yeah, your kid's, sick, go ahead, take off 15 minutes early. I'll sign your patients out to the night team and just make sure everyone has each other's back and is understanding when things come up.
I just wanted to specify and emphasize what Frida said, is that this is a parental leave, so both birthing and non-birthing parents get the 6 week and not just like this general sense of maternity leave.
And you can split those weeks up if you want. If you're like me and you ended up having multiple kids while you were a resident, you can like save 3 of those weeks for a future pregnancy if you were planning on such things. Or you could take an additional 6 weeks, but it would just extend your graduation. That would be the only thing.
Okay. Looks like this is the last one for the Chiefs for now. What are the opportunities available to learn procedural skills such as LP, EEG, EMG?
I can start with that. So new this year is, I guess, I don't want to, can we call it an EG boot camp? Yeah, an EG boot camp for rising PGY3s, which they're rising seniors. There are 2 weeks at the beginning of their PGY3 year where they just do full-on immersion EEG, technicalities, emergencies, anti-seizure medications, all of those things to prepare them to take their new role as a senior, especially when they're on call during the day or during the night. And then the rest of typically the PGY4s will cover some of the inpatient services that are typically reserved for the PGY3s. In addition to that, there's also, and correct me if I'm a little outdated on this, but for PGY2, we still do at least 1 week of your electives. It will be with the EEG lab where you start reading, normal EEGs, outpatient EEGs, and then with the staff that's working there and very supportive, you move on to like inpatient EEGs, continuous bedside EEGs with more abnormalities. Same with EMGs. EMGs for the one of your elective weeks as a PGY2, you do 1 week of EMG with clinical neurophys staff. This is also when you interact with clinical neurophys fellow if they're on the same week as you. This is an opportunity for you to learn the technicalities as well as you are able to do hands-on EMGs. And if you are particularly interested in just becoming more adept in that procedure, you can keep using some more elective time to do EMGs. LPs, you really will do them like all the time if you really want to. Like I like doing LPs. I kind of like, I think like Trey talked about last week, I think I did 2 or 3 LPs just because I like doing them and I was helping the inpatient service that was busy. We have during the neurology boot camp, we have a kind of like a workshop session where we also learn to use a handheld ultrasound device if you want to use it for some of your LPs. I did start using that at the beginning and then I just dropped it because I think I became better at identifying landmarks. But you will get a chance to do as many LPs as you want to, if you want to be offering to help some of your colleagues on the inpatient service. But we also have a scheduled Monday morning clinic where residents starting from PGY2 will literally show up to clinic to do planned outpatient LPs for a variety of reasons, either to diagnose demyelinating disorders or normal pressure hydrocephalus or really anything. The patients solely show up to get an LP done, and then you get to do it with the help of neuroimmunology staff that's on. So there's set times where you'll be able to do them, but you can also do them as often as you'd like them to do, as you'd like to do them.
And then I guess a few other procedures that we get training on. We have a headache specialty clinic, and so you can go spend your elective time out with them and get good at migraine, Botox, and some of the other things like trigger point injections or nerve blocks maybe don't come around as often as migraine for Botox, but you can learn those sorts of things. And then in movement clinics, there's a lot of Botox for spasticity, DBS programming. Trying to think of any other procedures. Those would probably be most of them.
Okay, question now for Dr. Abdel Wahed. How does the program help if a resident faces an unforeseen issue that impacts their ability to perform their duties?
Right. And it's kind of a very broad question. You can understand it from several different angles. So I think Frida and the chiefs touched on a little bit about like whether there's like health-related issues, complications. So there are mechanisms in place to provide you with however much time you need to be off and recuperate. If it's like a family emergency, etc. If it's a mental health crisis, we have several safety nets in place, including GME, like both departmental and GME resources available to help navigate whatever is going on, like whether it's burnout, if there's like any issues that's going on. So that's why we have several meetings with the residents through different stages of their training, just to make sure they have these safety net check-ins, especially if they want to talk about specific issues. Maybe one thing I would expand on a little bit more, which is the more common, is that what if somebody is not meeting their full potential and they're having issues with managing the workload or keeping up with responsibilities, or just like overall general transition is a big transition. Residency is a big transition. So we want to make sure we make it as smooth as possible. So we have also knowledge base resources. So we have recently been more and more implementing individualized learning plans for residents. So based on how they feel they're doing, based on how they get evaluations and feedback from their faculty, from their peers, etc. So we meet with the residents, we see how they feel things have been going, we look at their evaluations, and then we come up with a mutual plan where we implement it and we try to get them as specific and individualized feedback as much as possible to help them reach their best potential. And my goal in the future is to have an individualized learning plan for everybody, and not just because people are struggling, but like just make sure you give you better guidance on how to do better, rather than just say, hey, you're doing great, read more and move on. So we have several safety nets, we have several people available to help you through whatever life circumstances, mental health circumstances, knowledge circumstances that you're going through, to make sure we support you through it and get you to be the best possible neurologist you can be.
I could just add some institution-wide resources that we have. We have a well-being team as part of the Graduate Medical Education Office. I didn't mention this, but in addition to being vice chair for the department, I'm also associate dean for graduate medical education, so overseeing all the residencies and fellowships. We have a relatively unique well-being structure with now two clinical psychologists who serve all GME trainees only. So they are available for counseling or coaching, and it's completely outside the hospital medical record, 100% free, and dedicated to trainees. As part of that team, we also have a psychiatrist who does more advising and outreach. But new this year, our well-being team implemented a risk assessment for transition to residency, using a validated tool that, based on things like levels of support, whether someone was familiar with the area, and other factors that could make the transition to residency even harder than it is for anyone. And based on those, they created opt-out appointments for anyone who was in the middle or high risk category for having a difficult transition. So it's kind of just being part of the process that we know it's hard, and these resources are in place for everyone. Not everyone will want to take advantage of it or feel that that's the right thing for them. We also this year piloted getting primary care provider establishment for all incoming interns. We had schedulers at orientation, basically getting people plugged in and booked for appointments. We also had faculty on hand for any urgent issues like needing a prescription refill, having moved from somewhere else, and not having a provider yet. We're excited that in the next couple of months, we're going to expand that to all of our existing residents, who told us this was sometimes a challenge, because there's just a shortage of primary care providers. So the hospital basically hired some providers to be dedicated to our residents and fellows for primary care access.
I just
Okay.
want to make a comment that is really cool what you just outlined. It's so important for residents to be focused on their own health, own well-being, and getting established with a primary care provider is so important. I know so many young people just feel very healthy and feel good, but it is a really important piece, especially during residency. So thank you guys in GME for setting that up. I think that's a really wonderful initiative.
All right. We'll start with the Chiefs on this next question. What are you most proud of about the program?
Okay, I'm gonna beat Zach and Trey on this, but I think hands down the culture. I think it's a big, big thing. And you'll notice during your interview trail, I think what really stood out, me having done medical school here, but I also had the chance to interview at other places. Iowa was the place I was like, welcome, look at what we have to offer you. And other places where maybe did not have the same vibe as Iowa. And having been here for a long time, I'm officially an Iowa transplant. I'm going to be staying here long term. But definitely the culture, the residents, the staff, and the mentors that I've made along the way, both official and non-official. I have a lot of, I call them non-official mentors. Like it's easy for me to just text Dr. Abdel and say, hey, I have this cool patient you want to talk about. So I think that's something that's very, very unique. And you can also tell by how many current staff did training here and didn't want to leave, or they go and do fellowship elsewhere, but then come back, like a lot of our staff. And I think that says a lot about the program and the culture here.
Yeah, I think for me, for like the program as a whole, one thing I I think I'm proud of on behalf of the program is like when we make a good impact on medical students who come through our rotation, or even different services that we work with in the hospital. Obviously, like not everyone's going to go into neurology or love neurology, but it's always great when you like see some students a couple months down the road and they're like, "Hey, I really learned a lot about neurology. I think fondly of that rotation. I miss you guys. I'm doing internal medicine or whatever, but I really like that neurology rotation. I'm always proud of those moments where when you go down to the emergency room and you got a smile on the face of some of your favorite co-residents from down in the ED or the nurses down there, and they're glad to see you and excited to see neurology and like working with us. So I think some of those interactions with our other colleagues and our medical students.
Touching on a few things that we've already discussed tonight, outside of the culture, but like the amount of growth that I've had over the last few years has been tremendous, and seeing that growth in my colleagues, as well as the current PGY3s who are our juniors, and knowing that we had even a small hand in how far they've come over the past year, and they get to see how far they've grown working with the new PGY2s, and just kind of being here tonight, realizing we went through this, but only 4 years ago, and now we are kind of, Chief's an amazing program. It's kind of remarkable.
I think it's my turn now, and definitely echo everything that Trey, Frida, and Zach mentioned. The culture here is amazing, and just like no other place I've interviewed at or been to felt like had similar people. Like everybody asked me, like, you've been here forever, what kept you here? And it's very easy answer. The people I get to work with. What I'm most proud of is actually the residents, just seeing them grow, like Zach said, throughout, like coming in from like terrified interns and then seeing them grow into their own and become like three awesome chiefs, like the ones you're seeing here, or like they go out into the world and do amazing things, and then you run into them at AAN or whatever other conferences. So I would say it has been really the people that you work here who had this quite an amazing environment, and not just like the faculty or residents, but also like the other people that you work with. So our pharmacists, for example, our social worker, our therapist, the people that we work with in clinic on a daily basis. It's just like really fun place to be. So like you come into work and often it doesn't feel like work just because you're seeing your friends and your second family here. The patients are pretty awesome as well, just like it's Iowa, so everybody here is pretty nice. So like I think Zach also mentioned earlier, like you get to quip and joke around with your patients, and I have a lot of like my follow-up patients that I just like kind of a high and by, we just talk about life and how are the kids and did they graduate and how are the pets and things like that. So I just like it does not make it feel like work. I can talk about all of the achievements and subspecialty and exposure and education and blah, blah, blah. But honestly, it always comes down to who you work with, and especially all the people sitting on this call here. Like they mean a lot to me, and they all played huge roles in me wanting to stay here.
Yeah,
I'll chime in.
Oh,
Go
sorry.
ahead, Andrea.
Okay. Yeah, I definitely echo everything that the panelists have mentioned. I do want to say that I'm so proud to have Caroline as our program coordinator. She's so organized, really, really good, knows so much about neurology programs, has a lot of connections with program coordinators at the university, but then also across the country, has done a lot with the national programs. So I'm just really proud to say that she's ours and really enjoy working with her. And I know the residents do as well. So yeah, thank you all. It's just so much fun to work with you.
But all crush and burn without Caroline. So she's the real boss.
I would echo what everyone else has already said, and it all relates to the people and the culture. I would add, I am really proud to work at a place where the residents take care of each other. in addition to the patients, the students, and honestly, us faculty. The residents are the glue, or the foundation, however you want to phrase it, that hold all of it together, and are it's just real, as someone else said, it makes it fun and easy to come to work when you get to be a part of that. And that's definitely what we're aiming for.
Absolutely. I have one last question for the chiefs that I'll circle back to, and this is, how does the program prepare residents for fellowship choices and applications? And I think we've heard a little bit about this.
Yeah, I think we've heard a little bit about it, but in kind of separate little pieces. So I guess, part of it's through the early exposure to the different subspecialties that you get during your Y weeks and your early elective time in PGY2. Um, and then kind of, preparation for you have your mentor that you're assigned that you meet with a couple times a year, and that's always something that you're talking about. We typically host a session every year where um, some of the staff or current fellow or the senior residents who have already matched will host kind of a fellowship Q&A panel. Um, and then let's see, you're given, I think, 5 days or 10 half days for fellowship interviews. So you're given protected time to, schedule those interviews, excuse from clinical duties for all of that. Um, what else did I miss? Zach, Frida's, anything else? I guess, we're constantly getting blasted with emails about this or that conference, for movement disorders or epilepsy or something. And a lot of times it's, respond to that quick and take that funding before someone else does so you can go to XYZ conference and, see some more research on that or talk to some other people in the field. But yeah.
I think you hit on everything. Great
Okay.
job.
Okay, awesome. Well, those were all of our pre-submitted questions.
I just want to point out, Zach, that Trey makes fun of your beard being gray. He still can't grow one, so that's understandably frustrating for him. But I've got your back.
Thank you.
Mhm. No comment. Yeah, and I think all jokes aside, I think kind of building on the topic about fellowship too, you also don't have to do a fellowship. And we have maybe one or two people every year who do that. And I think they feel very well trained to go out into the world of general neurology and prepare to tackle a lot of the different problems that you see and handle most of what comes through a general neurology practice.
We have a question in the chat that Frida could answer about the research track, what it typically looks like for residents. Are they dedicated weeks away from clinical service or electives? How many weeks per year do residents in the track spend on research?
Yeah, so being part of the CNSTP formally, there's certain milestones that you kind of meet throughout the year. Like if you are set on continuing to do research, if you've already been involved in research, for the first year for PGY1, you kind of want to be thinking about, okay, what type of research do I want to do? I need a research mentor. You kind of make time to meet with them. Like I use part of my outpatient block to rotate and to kind of have an idea of like a tentative timeline. Um, there's usually like one meeting a month or so where the CNSTP program kind of goes over through some of these milestones, and you kind of have some of the members give talks, and different years they talk about like specific aims. Part of it, being part of the CNSTP means that you are planning on submitting a UE5, formerly known as a R25 training grant. And that is and what comes with that is getting about 6 months of, hi Danny, 6 months of protected research time, usually sometime in your PGY 3, maybe more, PGY 4 year. And that comes with asterisks because part of ACGME, you need to continue seeing your clinic patients every 5 weeks. So you have about 6 months of protected research time where you're working on a research project of sorts. I'm doing a lot of basic research. I'm working on writing a grant, doing some manuscripts, things like that. But every 5 weeks, I still see my clinic patients just to have that continuity of care. You are expected to submit a UE5 grant proposal or a similar type of mechanism, and then at the end of PGY 4 year, you will give a grand rounds presentation of kind of like what you've done or your plans. But the caveat with this is that you are using a lot of elective time to, be able to do this research. And so you won't have as much elective time to do other things. Like if you want to do some extra neuroimmunology rotations or things like that. But you use a lot of your research time in your PGY4 year or your elective time for research specifically. So that's why it's maybe best to wait to do that 6 month block in the PGY4 year when you have a lot more elective time to use. Hope that answers the question.
All right, I think we're coming up close to time. So I want to thank everybody here for attending and hearing about how wonderful our program is. And I want to thank our panelists for taking the time and showcasing again how wonderful of a group we are. So thank you all very much. This will be recorded and posted on our website. So please take the time to look at our website. There's plenty of helpful information out there. We're actually updating it right now. So take a peek. This will be recorded if you need to go back and listen to specific questions. And otherwise, best of luck in this coming recruitment season. And I look forward to working with all of you as future neurologists. All right, you guys take care and thank you very much.